Thank you, David. Thank you, Uma. I want to congratulate Rick McDermott and Steve Hanauer on another incredibly successful meeting. So I'm here to try to convince that 79% of you who think that mucosal healing is an end-all and be-all to reconsider. What we're talking here about a patient with ulcerative colitis who's doing just fine on azathioprine, but whose endoscopic appearance shows moderate activity. And so I think that's where I'm centering this, is on endoscopic activity. I have a couple of disclosures to share with you first. When I was in high school in Mississippi, I was on the debate team. And my partner and I went to a debate tournament in Yazoo City, Mississippi, and we made two of our opponents cry. And they were not tears of joy. So, fair warning. Next, I want to show you some additional disclosures. I'm going to talk a lot about the Mayo score because that's the endoscopic score lots of people are using. And I have received money, and I'm showing you the money, and this is kind of editorial, because dollar amounts matter. Remember back in 2009, Tim Geithner got nominated to be Treasury Secretary, and he was confirmed because, yes, he had unpaid taxes, but it was only $34,000, whereas Tom Daschle, nominated to be head of Health and Human Services, same thing, unpaid taxes, $124,000. So in the court of public opinion, dollars matter, and the conflict of interest world is pushing for dollar disclosures. I'd like to push for that also. So I'm going to show you a case. This is a 32-year-old patient with ulcerative colitis for 16 years, originally required steroids but was responsive, so as we've heard earlier this morning, that's a good sign that this patient would do well on azathioprine. And indeed, on combination mesalamine and mercaptopurine at reasonable doses, this patient has been asymptomatic for years, but at surveillance colonoscopy, there was moderate disease activity as well as some normal areas. And biopsies showed patchy, minimally active chronic colitis, some areas of inactive colitis, and some even normal biopsies, but no dysplasia. And the C-reactive protein was up a little bit, but the patient felt fine. So we as clinicians, what do we do? Should we stay status quo? Should we juggle the mercaptopurine dose to get optimal levels? Should we add in biologic? Well, of course, the middle choice is a gimme. We would all, I think, these days say, let's optimize the dose. So we get down to the status quo versus anti-TNF alpha. Now, I had a very long title for this talk, and what I would like to do is simplify this title into the following. Mucosal healing may be like a fedora. And you can see in that middle picture that Johnny is sort of, it looks like he's thinking about mucosal healing right now. So why do I say that? Because let's look at these. So fedoras, who are they popular with? Well, hipsters, movie stars, some baseball or some college football coaches. Mucosal healing's very popular with the FDA. They want to see something definite, not just symptoms. And then marketers. Our drug gives mucosal healing. You know, that's big. Fedoras are easy to spot. Mucosal healing, not so easy. You've got to do a colonoscopy or a flex sig, and in an accountable care organization environment, doing a procedure that is not really that valuable may not be the right thing to do. But the bottom line, why are fedoras and mucosal healing similar? Neither are really important, and I want to show you why. I'm going to go through a checklist of things, and I'm going to start with, because the definition of mucosal healing, endoscopic mucosal healing, used in the trials that we base all our decisions on these days, is pretty fuzzy. So what is mucosal healing in clinical trials? Well, it's a Mayo score of a 0 or a 1. So either it looks normal or it's not quite normal. It's kind of erythematous and maybe a little granular. Now, my colleague Ken Schroeder, who I think is probably in the audience, published this study 26 years ago with this scoring system, and one of the criteria was the endoscopic score. And as you know, Ken's a straightforward guy. Things are either normal, mild, or moderate, or severe. So 0, 1, 2, 3. So this score I looked up recently on clinicaltrials.gov, typed in Mayo score, and there are 413 studies now using this. So this has kind of become the gold standard for mucosal healing by endoscopy. But the definition has become fuzzy. It's not being used as Ken Schroeder recommended it be used. And I would suggest to you that a Mayo score of 1 is not as good as a Mayo score of 0. Back in the 2000 presidential campaign, this man popularized the term fuzzy math. It came back to bite him in the Great Recession of 2007. And I don't think any of us really think 0 and 1 are the same. But if you look at trials, Bill showed this same trial. What I've done is gone to supplemental table 1 and made a bar graph. Now this is from Act 1 and Act 2, and you'll see 484 patients got infliximab, a couple of hundred got placebo. Now in the IBD world, that's a big study. In the real world, if you look at trials with coronary artery disease, we still have sort of small studies. So we always recognize with the p-value, there's still a chance alone factor that we could see differences. But I want you to look at these different colored bar graphs. These are the Mayo score of 0, 1, 2, 3 at week 8. And although the statistics were figured based on the Mayo score of 0 and 1 compared to a score of 2 or 3, I think you'll agree that the differences in a Mayo score of 1 and a Mayo score of 0 are pretty different. If you look at symptomatic remission, if you get a Mayo score of 1, it's a heck of a lot less for each category than a score of 0. So are we really fooling ourselves when we look in there and say, oh, well, there is mucosal healing? Yeah, it's a little red, a little granular, but that's okay. Well, it's not really okay. It's fuzzy. There's a real difference here. So treatment based on mucosal healing not only may not be valid, but it actually could be harmful. I want to show you a study published in the Inflammatory Bowel Disease Journal last month. This was a study of 2 German mesalamine studies. Say big patient numbers, you'll see over 1,000 patients, still kind of small in the grand scheme of things, but over 1,000 patients in whom remission was looked at as symptomatic remission, endoscopic remission. They used the Rachmaninoff score, which if the score was greater than 4, then that was considered mucosal disease activity. 4 or less, that was remission. Kind of like with the way the Mayo score is being used. So you could have some inflammation and still be called remission. And then what they added that I think is very important, that I'm going to make a case for, is the histology. And so this was a post-hoc analysis. But look what happened. Now, I'm not going to show you a bunch of bar graphs because it was very confusing as I read through this. But if you get down to the bottom line here, they had endoscopic mucosal disease activity in 13.7% of patients in whom the histology looked normal. So if you looked at a number needed to harm, you come out with about 1 out of 7 patients who have some mucosal disease activity who you advance to biologic therapy will be harmed. Now you may say, well, the harm from biologics, it's not that great. Well, it may not be that great physically, it's certainly great financially. And so I don't think we do patients a service to put them on a drug, 1 out of 7, that may do no good, may be unnecessary. Now, in the long run, mucosal healing really isn't worth much. And I'm going to use the same study that Bill showed to make this point. And I've given this a gold seal of approval in the top right because among those mucosal healing advocates, this is the hallmark study. This was a population-based study, one of the Ibsen studies, inflammatory bowel disease in southeast Norway. So 354 UC patients. They all got colonoscopies initially and then after 1 year and after 5 years. And if you look over on the right, wow, the patients who had mucosal healing had only about a 1.5% chance of requiring colectomy compared to those who didn't have mucosal healing. Now, this was the same deal they included in mucosal healing, a little bit of inflammation here. However, I have trouble with this study because if you look at the predictors, what predicted who would get mucosal healing? Well, it was people who went to college, if you had more than 12 years of education, or if you had extensive disease. So if if you look at other factors in the paper, what did not make a difference about mucosal healing? Age, gender, the medications you got, smoking history, family history of IBD, all the things that we might think would have effect. I have a hard time knowing why going to college keeps you from, having a colectomy. So I'm a little suspicious. If you look further in the paper, okay, and if we look at colectomy, why are we calling it colectomy as the endpoint? It's sort of a surrogate marker for medically refractory disease. But you and I know that other patients go to colectomy besides just medically refractory disease. Sometimes it's cancer fear, sometimes it's adverse effects of the medicine. At least in the US, probably not Norway, it's they can't afford the medication. So unfortunately, patients sometimes need surgery. So colectomy may not be the ideal endpoint. But look at other endpoints in this study in terms of mucosal healing versus no mucosal healing. So if you look at 5 years, at what was going on in those patients who had mucosal healing at 1 year or not, there was no difference in remission rate at 5 years. There was no difference in complainers. In fact, fewer complainers if they didn't have mucosal healing, numerically, and no difference in mucosal healing at 5 years. So if we look at a bunch of other broader endpoints, I think the idea of the colectomy endpoint being so important fades a bit. Histologic remission is probably what's really important, and Bill's made this point as well. So Stuart Riley, who's in Sheffield in the UK, did this study a long time ago. He took patients who had endoscopic healing by the same criteria. If you look at it, it was normal or erythema, so that'd be a Mayo score of 0 or 1, sort of what we're using these days. Then he came up with the Riley histology score, and if you look at the scores here about who does well in terms of relapse at 12 months, those who had histologic remission were those who did well. It didn't matter about their mucosal healing endoscopically. A study from Beth Israel in Boston, just out in publication, looking at 103 patients who are in a surveillance program for ulcerative colitis. So they probably got pretty mild disease anyway. Now, I like this study because they treated the Mayo score properly. You'll see they divided 0 from the other group, but you'll see the big difference there in using the Gabos score. That's a score based on a Belgian pathologist score in which a Gabos score max is 5.4. If you're 3.1 or less, you're in remission. And of those who had a Mayo score of 1 or more, if you look in the graphs in the paper, a number of them had a Gabos score of 5.4. They had very active inflammation despite a Mayo score of 1. So we're fooling ourselves if we say a little bit of inflammation in the colon's okay. And so back to that German study where we looked at patients in the mesalamine trials, the ones who 1 out of 7 were going to hurt if we treated. If you look at the endoscopic and histologic activity at baseline compared to after treatment, those who had active histology at baseline didn't do as well. Their clinical remission rate was lower. You can kind of think of histologic remission as like having an increased CRP in trials. Those are the ones who really need further treatment. So I think we should be looking at histology, not endoscopic outcomes. So histology is a better measurement. We're endoscopists. We like to make decisions based on endoscopy, and maybe there's still a role for us without having to turn to the pathologist. Here, a study from Italy looking at high-tech endomicroscopy. If you look on the right, low inflammatory activity, medium, and high based on putting fluorescent dye in the colon. Those with low histologic activity stayed in remission. So we may be able eventually to do this by endoscopy anyway, but not by just looking with white light. So endoscopic mucosal healing without histologic healing may not protect us from cancer. Bill pointed out that active histology is a risk. So if we're fooling ourselves thinking we've got endoscopic remission and ignoring the fact there's still active remission, a study from Mount Sinai looking at the more active inflammation you have, the higher the risk of advanced cancer. So let's look beyond just mucosal remission. And ultimately, population-based studies are what are really important. So I'm going to digress a minute. Let's pretend we're looking at babies born on 3 consecutive nights in a little hospital in Minnesota. Let's say Hibbing, Minnesota. So who's from Hibbing? Well, Roger Maris, Kevin McHale, Bob Dylan. So on the top, if we say the blues of the boys, we've got Roger, Kevin, and Bob, and then we got girls, and then the next night it's all girls, and the next night it's kind of a mixture. So are these sequences equally likely? Most people would say, no, 6 in a row, that's not as likely. This is a great book. Daniel Kahneman got a Nobel Prize in economics, but he's written on decision psychology. All of us kind of look at psychology, the law of small numbers. The smaller the numbers in the group, you know this, the more variability. So there's just as much likelihood of those 6 girls in a row as boys and girls. Well, I'm kind of stretching here, but if we look at studies showing that mucosal healing are all associated with great outcomes, all of our studies are relatively small. 6 in a row doesn't mean that we've proved the point. So I think what we need is a litmus test, something that really will tell us whether what we're doing, our intervention, is making a difference. This study from Nice, Filippi, who's in Nice, looked at pre-biologic error versus the anti-TNF error and looking at colectomy rates. Again, colectomy as a surrogate for mucosal failure of medical therapy. We really haven't showed a difference yet. So what do we do with that patient I showed you? I think, as we've heard before, as Feza pointed out, it's shared decision making. We need to share our uncertainty about the current data with the patient and make a decision as to whether you and the patient think that additional therapy is warranted. So in conclusion, mucosal healing is an imperfect endpoint convenient for clinical trials and marketing. Histologic healing is probably more important. Population-based studies, not treatment trials, is really what we need. And for now, I think we should hang up the Fedora and hang up mucosal healing until we have more information. Thanks.